Welcome to episode 202 of the Urology Coding and Reimbursement Podcast. I'm your host, Scott Painter, with my co-host, Mark Painter and Dr. Ray Painter. And today we want to welcome back Dr. John Lynn. Dr. Lynn is a solo practitioner in Gilbert, Arizona. And if you don't know who John is, hopefully a lot of our audience does know John. But if you don't know who John is, he is the founder or the manager of the Thriving Urology Practice Facebook group. And John, you want to share a little bit about the Facebook group and how people can join if they're not a member already?
You bet. I like to call myself the modern day Robin Hood, if you will. You see, I take from the information rich and I give it to the time constrained poor. To that end, I created this Facebook group, many years ago, out of frustration for a lack of a centralized area for urology practices in the United States to get relevant and up-to-date and immediate response to their questions regarding practice management, coding, and billing. So I know some vendors will be listening to this podcast. Sorry, only urology practice folks are allowed in the U.S. and no vendors allowed. It's a way for us to get together and talk about anything and everything regarding your practice or personal finances, or where to find that prostate biopsy needle, or is this code included in this other code, or can I use this modifier? So pretty much anything you can think of.
Well, thanks, John, and thank you for joining us. We're excited to have you, and always love to have the episodes where you're on with us. Today, we wanted to answer a couple questions and then share some breaking news as far as what's coming up, or at least that the 2025 proposed rule is out. We haven't had a chance to go through it yet, but we will soon, and we'll talk about that. All right. The first question we have is, we use modifier 55700 for the MRI fusion prostate biopsy. The docs want to use 55706 instead when MRI fusion biopsy is done with the transperineal approach. Is that okay? And for the reference, the 55700, the description is the biopsy, prostate, needle or punch, single or multiple, any approach. And the 55706 is biopsies, prostate, needle, transperineal, stereotactic, template-guided saturation sampling, including imaging guidance. All right. Mark, what do you got there?
So MRI fusion biopsies have been a rough thing to navigate as far as getting appropriate reimbursement for the extra time and the extra equipment that you use. So we've had a couple of things. I know that in episode, I think it was 194, we discussed some issues surrounding the use of some of the guidance codes or the radiologic services. So I'm going to and I don't think I can discuss one without the other. One of the things that I am going to look at for the 55700 and the 55706. So the differences in the code, or the code. So the 55700 really does allow for any approach and single or multiple biopsies. So it's a pretty broad code. It doesn't need to be transrectal. It can be transperineal. So that's one of the hurdles we're up against. And I do understand the need or the desire to do the 55706 because most transperineal biopsies, you're going to go into a facility to actually perform those. And I know that's not all, but I know that most are wanting that additional level of anesthesia for those particular biopsies. But the other things that the 55706 has that makes it a little more restrictive are the fact that, one, it has to be transperineal. And then two, the stereotactic template-guided saturation sampling is the other definitional piece that we need to get around. Now, there is nothing within CPT, and really not a lot that is out there that has been published to define a saturation biopsy. Is it a saturation of the entire prostate? Is it a saturation of an area within the prostate surrounding a suspicious location? What is it? Is it 20 samples? Is it 30? Is it, how many samples are there? That's not really well defined within the CPT nomenclature, and we haven't seen the AUA officially weigh in on that definition. Now, so the two things that I would say that if you are thinking about using the 55706, you do need to meet those two parts of the code, that it is transperineal, that you are using some type of template guided sampling, and that you are saturating at least an area, if not the entire prostate, so that you can meet that base definition within the CPT code. And so that might be something that you can try if in fact that is what you're approaching. But notice that image guidance is included in this. So that would mean that you could not bill for the fusion guided portion of the biopsy. The diagnostic biopsy, the diagnostic transrectal, if that needs to be done, that's really not part of the image guidance, and might be something that in some cases you could bill separately for, the 76872. But the actual fusion guidance, to me, would be included when you look at that CPT definition. So you do have some different guidance issues that are out there. Now, the second thing that unfortunately we need to consider is that the payers are weighing in, trying to put some definitional guidance around the saturation biopsy. We've been reading through a number of different policies and dealing with a number of different approaches that these payers have taken relative to the 55706. At one end of the spectrum, we've got groups like Blue Cross and Blue Shield of California and a couple of others that have basically determined that a saturation biopsy is experimental and therefore non-covered. So that's one end of the spectrum. Then kind of in the middle, we've got Aetna, who basically has defined the saturation biopsy as number one, being needed only for patients that have already had a biopsy and now have a PSA and some imaging that is and even some restrictions on what type of cancer has been detected. And then further have gone on to say that they require 30 to 60 cores to actually meet a saturation biopsy. We have others that are at 20, and then some that are silent, that you may be able to actually submit this code and get paid. So it really is, and we say this all the time, payer dependent is important to understanding this. So the 55706, really do some research with which payer it is. And if they have policies published, you're going to need to make sure you meet those policies, or you're going to be stuck with a denial. And we've actually gone through now some peer-to-peer reviews with a couple of payers on the experimental side, and they have upheld their experimental ruling. So it is something that I totally understand that you're wanting to use this, especially in the facility setting. It does provide a little bit better payment. We do need to start off with Again, that's transperineal. It is a template guided saturation biopsy, so you'll need that. You'll also want to very carefully add in your medical necessity as to why you've needed to use this approach for this particular patient. Special circumstances are probably going to be required given what we're seeing in the marketplace. So those are all issues that you need to really take a look at. And then, of course, I'd encourage you to listen to our episode 194 with regard to the guidance issues and what you can and cannot charge for that MRI fusion if you're using the 55700.
John, any comments on that?
Yeah, this is a question that came from one of the members in the Thriving Urology Practice Facebook group. So I've said this before. The more you know about coding and billing, the harder it is to just simply answer yes or no to the question. And that's why the long explanation that Mark gives, because I remember attending multiple meetings, Urology Advanced Coding and Reimbursement seminar meetings for many, many years. And I've always wondered, why does it take Mark so long to answer a relatively simple question? Yes, conceptually, it's simple, but it is not easy. That's the problem. The more you know, the harder it is to say yes or no. Because every time I read a question like this, I always want to know, okay, what exactly are you doing? In the past, Pearl, who asked this question, said, we used 55700 for MRI fusion prostate biopsy. And now the doc's using transperineal approach. Can they use 55706? And the answer is nuanced. It depends on the payer, number one. And number two, is your doc satisfying all the criteria within 55706? Yes, it's a transperineal approach. Is it a stereotactic templated guided? And is it a saturation biopsy? So those are all criteria that have to be met. And also, if you're doing 55706, you don't, unless you are actually doing the diagnostic portion of the ultrasound guidance, you don't get to build that code because imaging is included in 55706 versus in the old way, 55700, you get to attach an imaging guidance either for the biopsy or just the diagnostic portion of the ultrasound imaging biopsy. That's why it's so difficult to answer, Pearl, when he asks this question, is that okay? It's yes and. It's never yes or no. Sorry to be so opaque whenever we answer these questions.
Ray, any thoughts?
I think Ray dropped out.
No, I
here.
don't have anything to add. I think that they've covered the fact that you have to pay attention to the details.
Indeed. All right. Okay, let's go on to the next question we have, and it came from Kimberly. And Kimberly says, can someone explain to me if codes 52214 and 52224 can be billed together? If yes, what modifier are you using? Also, how is code 52224 a component of 52214? These codes blow my mind. And the definitions of these codes, the descriptions are for the 52214, cystourethroplasty with fulguration, including cryosurgery or laser surgery of trigone, bladder neck, prostatic fossa, urethra, and periurethral glands. And the 52224 is the cystourethroplasty with fulguration, including cryosurgery or laser surgery, or treatment of minor, in parentheses, less than 0.5 centimeters, lesion with or without biopsy. All right. And Mark, what do you got for this one?
So let's see. In deference to John's other can I give a short answer to this one? No. Unfortunately, I can't. So I'll try. I'll do what I can. So, yeah. So first of all, again, now let's look at the definitions of the codes. So one is fulguration. So fulguration, in that particular sense, the 52214, includes trigone, bladder neck, prostatic, fossa, urethra, or periurethral glands. So this is going to be fulguration of any of those areas. And then the 52224 is fulguration or treatment of minor lesions. So without the actual listing of, particularly where it is located. So when we look at fulguration, you can do fulguration for bleeders and different treatments or different problems within those areas. And of course, both of them require cystourethropy. So one is a little bit broader in what the target is versus the 52224, which is really focused on fulguration or treatment of a minor lesion. So you kind of look at those as the target is, the treatment of the lesion or the fulguration. So it is kind of hard to separate those two unless you look at kind of that differentiator again, which is trigone, bladder neck, prostatic, fossa, urethra, or periurethral glands. So, and then of course that differentiation would lead me to say that 52224 is really focused on bladder, and the 52214 is focused on the specific areas located within the description, the trigone, bladder neck, and so on. So you've got a location differential there. So that's where I would look at separating when you would use those two different codes. And as far as the bundling edits that are out there, there's no way I can explain why codes end up bundled the way they do. I can tell you the process, but that final decision is really based on coding patterns and a little bit of medical, let's say, juju sprinkled in as they look at all those things. So the best way to find out if you need a modifier is to use the bundling matrix in AUA Coding Today. Put the codes in the bundling matrix, see if they're bundled, and now you need to find out if the modifier is required. So in this particular case, specifically looking at 52224 and 52214, if you did fulguration in both locations to treat different issues or different lesions, that's when I would use the two codes and the same time, and I would use an XU or potentially an XS, because you've got potentially a different structure, but probably the XU or the 59 modifier would be the right way to go with those two. And then the last thing I'll mention while we're in the bladder cancer codes is if you're using bladder cancer as your diagnosis and not the unspecified neoplasm, remember to use location. The C67.9 is being denied routinely as not a specific diagnosis. So if you're using bladder cancer as a diagnosis to treat a bladder lesion, use the location. You know where you took that lesion from, and make sure you use that diagnosis code. And then, of course, document the size. Maybe the 52224 wasn't the right code because it was a slightly larger than 0.5 centimeters. Document that size so you can bill appropriately for what you've done.
John, what do you got?
There was an episode that we did a while ago about bladder tumor, TURBT, fulguration, etc. So definitely look for that episode. The main thing is we've been harping on this for so long. It's writing down for the doctors, writing down what you are thinking and what you are seeing. For most of us, this is the scenario that comes to mind is I see this patient with gross hematuria, I do the in-office cystoscopy, and I see multifocal tumor, sometimes involving the prostatic urethra, sometimes the bladder neck, and then I take the patient to the operating room, surgery center, or the hospital, and then I perform a 5-2-2-2-4, removing small tumors less than 5 millimeters, and I resect these tumors at the trigone, bladder neck, prostatic fossa, urethra. So the first portion, the small tumor resection less than 5 millimeters, will be 5-2-2-2-4. And then if I resect these specific areas that are covered by 5-2-2-1-4, then I would use that particular code. So it is important for me as the surgeon to relay that information to my coding staff. And here comes the important piece. It's a marriage between what you actually do and how you describe what you did while understanding these crazy coding rules. The more you understand, the more you know, the easier it is for you to get paid, because it is easier for your coding staff to convey that information, translate what you did to these specific codes with the modifiers so that you can be paid appropriately for all the extra work that you do, because you know that these CPT codes undervalue the skills that are needed. And I was doing a distal ureteroscopy yesterday, and I was thinking, if I push a little too hard, I can perforate this ureter. And the amount of money that I'm being paid to do this procedure, the amount of pre-op work, post-op work, the actual procedure itself, how long it takes to actually carry out this one procedure, the payment I'm sorry to say, it's horrible. So if you're actually doing the work and you're being underpaid, try not to screw yourself by not understanding these coding rules. Back to you.
Very, very true. Ray, comments?
I'd just like to emphasize what's already been said. John, you stated it very nicely. We all know how to document exactly what we've done from a clinical standpoint, but it's the understanding of the concepts of the rules that really allow you to document, to give your coders what they need to get you appropriately paid. And so we call that documentation for reimbursement that you need to add to your clinical.
And let me add one other thing on there. With those of you who are dealing with prior authorizations, you want to make sure that when you submit for prior authorization and you've got a suspicion that you're looking at maybe some lesions in the prostatic fossa as well as the bladder, you want to get both of those codes authorized, and you might want to authorize the larger bladder tumor codes as well so that you're covered. And for you as a physician, if you've got a fairly limited list of what's been prior authorized, not only do you need to get your documentation down to support it, but you need to be able to communicate back to your prior authorization staff that there was a change if you didn't have what you did authorized, so that they can get that prior authorization redone within 24 hours or 48 hours of the procedure, 24 being the optimal, because otherwise you've done some work that now you're not even going to get paid for, which is another way to, as John said, screw yourself.
Yes.
We've all been there. We initially look in. So this is how crazy it is for the docs who may be new or may not be aware of this. Say you see the patient with the bladder tumor and you want to do a TURBT. Well, in general, there are 3 different sizes, 3 different codes when you perform a TURBT, depending on the size of the single aggregate tumor. Small, medium, large. Let's keep it simple. Small, medium, and large. If you say you are very, very good, you perform the in-office cystoscopy, you see this, let's just say a 3 millimeter tumor. Or actually, no, let's make it bigger. Let's make this a 3 centimeter tumor. And no, let's make that, no, that fits the criteria. No, let's make this a 2 centimeter tumor. So 2 centimeter tumor that is actively bleeding. And you look in, flexible cystoscopy, it's cloudy. You think that there's only one tumor, but then you take the patient's, you say, okay, I'm going to schedule this patient to resect a TURBT, do a TURBT of a 2 centimeter tumor. Your coding staff is going to, based on what you documented in your in-office cystoscopy note, get an okay or prior authorization through the insurance company for a resection of a tumor that is the medium-sized tumor, because that 2 centimeter qualifies for a medium-sized tumor. What Mark is recommending is, instead of having a coding staff getting a prior auth for just the one size tumor, consider getting the larger tumor size code authorized, prior authorization for that too. Say your staff doesn't do that, and he or she only gets the TURBT of the medium-sized tumor, covering that 2 centimeter tumor that you saw in the office. If you go into the operating room and you perform a TURBT of a 5 centimeter tumor because you didn't see it in the in-office cystoscopy, it is imperative for you to notify your coding staff as soon as possible, meaning that same day, because insurance companies will deny your claim if your staff were to code for the larger size tumor, which, as you know, takes a lot more work, effort, and the insurance companies will deny payment to you for doing the extra work because your coding staff did not get a prior authorization for the medium-sized tumor. But if you were to inform your coding staff that you did a TURBT of a larger tumor right away, and your coding staff is able to contact the insurance company within 24 hours of you performing that procedure, then you have the possibility of getting paid because you address this in a timely fashion. So anyway, I'm just trying to make it simple for everybody.
Very, very, very well explained. And I also want to circle back to the very first part of the question that Kimberly asked. And Mark mentioned this, but I want to just kind of give a few more instructions. She said, can someone please explain to me if codes 52214 and 52224 can be billed together? And Mark mentioned AUACodingToday.com. And in codingtoday.com, he also mentioned the bundling matrix. And what I encourage you to do, if you go to the show notes, the episode page, it's at prsnetwork.com/202. There is a link to get a free trial of AUA Coding Today so you can test out and try this bundling matrix. So once you log in, you can go get a free trial and go to the bundling matrix and type in these two codes and see what it produces, see what it gives you. And it'll show you that you can bill these two codes together, but you have to have a modifier. Gives you a little yellow caution flag. So we do encourage you to check that out. It does make things a lot easier. It's a quick visualization of that question. So, and you can add up to 20 codes if you wanted to in there, and it would show how they all relate to each other. So Kimberly, that's the best way that we know to give you a good, quick representation of what can and cannot be billed together. So, all right. I also want to mention that we have an event coming up, which we will be talking a lot of these topics, just like we talked about today. It's our Urology Advanced Coding and Reimbursement virtual seminar coming up on July 27th, and it's going to be from 9:30 to 1:30, 9:30 a.m. to 1:30 p.m. Eastern Time. And Mark and John are going to be leading us through that. They're going to be teaching us what we need to know, the most important things that you need to know as a urology practice. It's good for urologists, urology coders and billers, and other staff in the RCM world. So we encourage you all to do that. Mark, John, you want to talk a little bit about what you're going to cover and how the webinar, the Zoom, it's actually going to be a Zoom meeting, how it works and what you're going to be doing. And Mark, you want to go first, and then John, you want to share with what you're going to be doing.
Sure. So as I've been doing a lot of talks around the country recently, we've definitely found that people are getting better with the new E&M guidelines. But there's still some nuances out there and some questions here and there, definitionally speaking, that people are trying to understand. And I would say physicians and APPs, both, are still have a few things that they're leaving on the table because they're not understanding the nuances of, say, that probably the two bigger components that we see are risk and presenting problem, but we still have questions surrounding data. So it's really all three issues that everybody needs to understand. There's been some misinterpretations of different things. So we're going to spend some time on E&M coding, give you some good examples and kind of tear them down as to what falls into which level of service. We're going to go over modifiers. And, like the 59 we talked about today and the XS dose, and the global concept. And then we're also going to run through some of the new CPT codes we've got for 2024, give you some updates on what's happening around those codes. And then finally, we'll have had enough time to actually tear through the proposed rule. So we'll give you a kind of a preview of what we're seeing for next year. And I'm going to already plug that we're going to be giving a call to action. It's time for everybody to start lobbying their local reps and or their national House of Representatives and their senators to get off their respective bottoms and move forward with telehealth. Because right now it's scheduled to expire at the end of 2024. And that was echoed in the summary of the proposed rule that I was able to look at. And of course, we're looking at about a 2% drop in the conversion factor, actually almost 3. It's 2.93 for next year. So it's time to get active. It's not good enough to sit around and complain. It's time to offer some solutions and really demonstrate to your representatives and your senators that people need telehealth. We need telehealth. There's too many patients and not enough physicians. And being able to leverage telehealth, both telehealth and telephone support to your patients, are good medicine and good support services that you can provide to your patients and need to be paid for those. So we're going to talk a little bit more how to get involved, where to focus your energies in those areas, and then have a lot of interactive Q&A for the group in the virtual session.
Go ahead, John.
I'll give you an example. I was on a cruise recently, and I was able to join via Teams meeting on behalf of a fellow urologist, and he was actually on a Teams call with a bunch of United Healthcare coders and billers, who clearly, they're certified coders and billers. They have a lot of deep understanding of evaluation and management, and I was defending him regarding denials. He was being denied for certain work that he was doing. Clearly, these coders and billers understand the rules, but what they lack was an understanding of how things actually happen in the urology clinic, how the patient is actually seen, the workup. I was able to kind of push them back into their caves for them to regroup and not immediately say, we're not going to pay this particular urologist for the work that he has done. That can only happen if you understand not just the rules, but how to apply them in real life. The Urology Advanced Coding and Reimbursement virtual seminar is one of the ways that you can reach that goal, so that you can produce the work RVUs, and not only that, convert the work RVUs to the gaslighted payment the gaslighted low payment that we're all getting for the work that you do. So my bottom line is work, but make sure you are getting paid for the work that you actually do, the measly amount that you're getting paid for the work that you actually do.
All right, Ray, any comments?
Well, I'd just like to encourage everyone to attend the seminar. Mark and John do a great job of getting down in the weeds and explaining exactly why you have to do something instead of just tell you what to do. And you do need to understand the concepts and how to apply the rules. And that is doubly important for both the coders and the physicians. The physician needs to understand in order to give the appropriate documentation to the coders. So learn more. It'll be worth your while.
And let me just add one thing for like the evaluation management stuff that we're going to be covering in a couple of weeks at the virtual seminar. The first time the E&M rules came out was in 1995. It changed in 2021. So if you learn the 2021, the current set of rules, this will most likely last you throughout the rest of your practice careers. So think about the amount of revenue that you'll lose by not appropriately applying these rules. And that's why I keep going over this. You need to understand these rules, because if you're going to participate in this third-party payer game, you need to understand the rules.
Very, very true. All right. And so if you want to register for that, you can go to the episode page. Again, that's prsnetwork.com/202. And there'll be links that you can go and register for that virtual seminar. We hope to see you all there. All right. It's time to wrap this episode up. Once again, we want to thank ModMed for supporting this episode. If you're in the market for an EHR or practice management system, you can go to modmed.com/PRS Network for our listening audience. Also, we want to thank Urogen for supporting this episode as well, manufacturers of Gelmido. All right, let's get some final thoughts, and we'll end it. Let's go around the horn the way we've been doing it. Mark, you're up.
All right. Thanks, Scott. So, so we've definitely covered a couple of different things today, and different issues that are coding nuances. And I think the one thing I appreciate is that over the years, urologists and urology offices have been getting better, staying up with the rules and trying to understand all this. But the payers, of course, are also evolving and using AI to actually really focus on trying to look at more and more charts and their medical documentation. And we were told recently by an individual that they're requesting as high as 36% of charts submitted for medical record review. So there's no way to kind of dodge around the fact that your records are going to be reviewed and they're going to be looked at very closely in order to get payment. So when we talk about understanding the rules, you've got to understand the rules enough to marry the clinical effort that you've provided, the work that's done, as well with the medical necessity and the reasons for those treatment choices that you're making for your patients. So those are important things, and they do require, like anything, practice and understanding. So that's where we're trying to continue to move the bar forward to keep urologists at least even with, if not ahead of, the insurance companies in some ways, but also making sure that you can provide the services that you feel are appropriate for your patients, and still remain in practice, because we've seen a number of practices recently that just haven't been able to make it, and have made choices to sell or go to a hospital that they really didn't want to. So, again, the more we can help with all this, and the more you can help yourselves, that's what we're trying to do.
John, final thoughts.
That's a perfect segue, Mark. You mentioned how insurance companies are using AI to scrub the claims by the providers. When I asked ChatGPT about what are the current coding and billing conundrums, it gave me 10. I'll just cover the top, one or two. And the first one is education. You have to continuously educate and stay updated on what's going on with the coding rules. And as you mentioned earlier in the podcast, the new OPPS rules, Outpatient Prospective Payment System rules, just came out yesterday, literally. And it's signaling a 2.6% increase to the hospitals, and yet we're projected to get an approximately 3% decrease. And I agree with you. You have to contact your legislators and voice your concern, because as you know, inflation keeps going up. The Fed is not adjusting the interest rates. They're staying the course. So that means the value of your money is decreasing, and yet you're taking a pay cut. You've been taking a pay cut for the last 20 some odd years. It will behoove you to make sure, number one, you're not losing money for doing the work that you do. And number two, it is time for you to advocate on your behalf to the senators and Congress people to make sure they keep promoting the increases that are necessary in order to sustain your practices, so that you can continue to take care of these 10,000 men and women who are turning 65 every single day. So back to you.
Ray, final thoughts.
The devil is in the detail. And that is still true, particularly when it comes to documentation and coding. And so I encourage you to attend this seminar to get a broad view of what is current and what is going to happen. And if you want to be spoon-fed as far as the correct way to document for reimbursement, why check out our coding course. We have tailored it strictly to give you what you need to know and understand for documentation and coding.
All right. Well, thank you all for listening to this episode. We appreciate it. Appreciate your attention and listening and participating. So if you have any questions, if you have any questions, feel free to put them on the Urology Coding and Reimbursement group, which is on, again, the link is on this episode page, or you can put it on the Thriving Urology Practice Facebook group. So get those questions answered. We're here to help as best we can. That's all we have for today. Take us out, John.
Thank you so much for the privilege of your time. Happy coding.